Okay, so I'm going to try to squeeze a lot of information into a short period of time. And so I think I'll go through a few of the main questions that kind of outline what are body-focused repetitive behaviors. So we've got the questions sort of, what are these behaviors, who do they affect? And because we're talking about OCD, sort of where does this category fit in with OCD? And then what do we do? What do we do about what we know about body-focused repetitive behaviors? So body-focused repetitive behaviors is a term that I really like to describe things like skin picking, hair pulling, nail biting, thumb sucking, all of those behaviors that involve the body, which have some kind of a soothing effect on the central nervous system. Now, body-focused repetitive behaviors is not a term that is used diagnostically. I believe there was some discussion about including that as a category, but I'm imagining that that's not actually going to happen from what I hear from the more updated news. But I think it would be great if it was, because it captures something about what these things have in common without putting a label of pathology on top. So I think of body-focused repetitive behaviors in two different ways, and some of my clients kind of relate to one way of thinking of it, and some relate to the other way of thinking of it. So I'm going to give you both. And one is that body-focused behaviors can serve as action symptoms. What this means is all that mucky, internal, messy stuff that we have inside that we don't know necessarily how to fix. We all have that. There are ways that we all find to externalize problems in a manner that they can be temporarily solved. So where I might not know what to do with my anxiety, I know what to do with a pimple. I can pop it. I can feel satisfaction. So in that way, we can think of body-focused repetitive behaviors as ways of coping with problems that are a lot harder to solve. Another way to think about body-focused repetitive behaviors is as an over-grooming behavior. So if we think about plucking hairs, kind of maybe popping a pimple or two here and there, that's a part of regular grooming. We all do it. I don't know anyone who's never popped a pimple or tweezed a hair. But once it goes into a level where we don't have as much control over it, we're not just doing it for grooming purposes, we can call it over-grooming. We can learn a lot about these behaviors if we look at what happens with over-grooming in animals. They also groom naturally, and under certain conditions, over-groom. So you've probably all seen a dog or a cat or a horse doing some of those behaviors like licking off all their fur, and or even sometimes birds can pluck off their feathers. Horses can do different things. They can bite their flanks. All of those happen in certain conditions, and that's really important. Some of the conditions that animals tend to overgroom are the same conditions that my clients find as triggers. This can include feeling trapped, either in too small of a space or emotionally. It can include feeling invaded. I know once I got too close to a group of birds, and suddenly there they were, kind of over-grooming, and I had to move away, take their cue. And other things can be lack of stimulation, lack of social contact, and kind of an inability to get out some frustration. That's when horses tend to bite their flanks, when they don't have enough aggressive play with other horses. So just in terms of who does this tend to apply to? Who tends to be suffering from body-focused repetitive behaviors? Some of this is anecdotal. In terms of, I've been working with this population in my private practice pretty exclusively for 5 years, and I found a lot of similarities. And one is that there seems to be some underlying difficulty with sensory processing. So there's studies being done about what the genetic component might be to the disorder, and I think they'll find that it has something to do with sensory processing. I can't tell you the number of my clients who have told me that as children they didn't like the feeling of the tags on the back of their clothing, or the lining on their socks had to be lined up just right. Also, there's an emotional sensitivity, which has some difficult parts. It's hard to be emotionally sensitive. You tend to pick up whatever's in the house or environment and sometimes you can become the scapegoat because you're the one feeling things that are unspoken. It has some really positive parts. A lot of my clients are very attuned to animals and have the closest relationships with the animals in their households. So they tend to be, it's largely female, tends to onset around puberty. And what I've noticed is that my clients tend to be higher than average as far as intelligence goes, but possibly with some learning, some place that's difficult for them as far as learning goes. Again, the number of people who start pulling out their hair in a difficult math class is really noticeable when you go around it and find out when was the first hair pulled. It could be trouble with spelling, and it seems that throughout life, kind of school difficulties can really be triggers for pulling. Okay, so moving on to the intersection with OCD. When trichotillomania was first kind of introduced into the Index Medicus, before it was introduced into the DSM, it was introduced as an obsessive-compulsive neurosis. Once it was moved into the DSM, it was moved as an impulse control disorder. There's a lot of confusion because it has elements of both. It has that element of impulse control disorder in that it's kind of like an itch that you need to scratch. When there's a hair that's out of place or a pimple that needs to be popped or a scab that needs to be gotten off, that is a very impulsive piece of the disorder. There are also some obsessive pieces in terms of the behavior tends to be very ritualistic in terms of pulling out the hair, what you do with the hair. There's usually a visual part and also an oral part of what it feels like if you rub it on your lips. Same thing with scabs and other pieces of nail biting. Same thing. Sometimes it's what you do with the nail as well as just getting the nail off. So each person tends to have their own ritual. Different than OCD though, pleasure is a part of the process for at least 80% of the people who engage in body-focused behaviors. There's a real sense of pleasure and relief when you get that hair or you get that pimple. And then it might be followed by, pretty quickly by some regret, but that pleasure and relief doesn't tend to be as much a part of other obsessive-compulsive behaviors. Okay, and when I was thinking about the myths of trichotillomania and skin picking, I was thinking about kind of a way that I practice that's a little bit different than the way that a lot of people in this field tend to practice. What I've noticed in reading other literature and going to trainings with other professionals through the Trichotillomania Learning Center is that a lot of professionals view the behaviors as just a problem to get rid of. And so if it's just a problem to get rid of, the focus is going to be on the symptom and controlling it. And then success looks like getting rid of it. For me, what I found is that we learn a lot about ourselves if we can look at some of the unmet needs that the behavior is soothing. So rather than taking it away from clients, I really like to understand it deeply and help clients to respect what it has done for them in their lives, because it has helped them to cope in many ways with maybe sensory difficulties and whatever difficulties get piled on top. So one of my clients framed this issue in a beautiful way. She does both the picking and the pulling, and called these behaviors combined her blanket with thorns. So powerful, and it makes it so clear. Nobody wants their blanket to be torn away, and I don't want to tear away anybody's blanket. I want to help somebody look at why is this blanket so important to me, and then I also want to look at how do these thorns affect me? What's the balance here? Is it helping me or is it hurting me? And where's the balance? And then when there's enough understanding of what the needs are that are being met, and we can find other ways to meet them. Maybe it's related to an anxiety that goes through your head, and you're running through all your anxieties, and if you write them down instead, it's another thing to do with your hand, and you're not going to your hair, and it doesn't have the negative side effect. But that's very different than just trying to get rid of the problem. And that way, it also helps. What I've found is that a lot of people come to me after going through a very strict cognitive behavioral program. And they may have gotten rid of their behavior, but guess what? Another one popped up in its place. Overeating tends to be a great substitute for picking and pulling, and I'm not interested in substituting one out for the other. What I do find, the good news is that my clients, if I can work with them at healing on a deeper level, the progress we may find, which might be stopping completely, more likely it's going to be that we always know we're going to revert back in times of stress. But we can reach a manageable level where we have some control, and then I find that my clients are more likely to sustain their progress. Thank you.
Good morning. Dr. Stout and I are going to be talking about comorbidity. You guys hanging in there?
We're going to try to do it Academy Award style too, or go back and forth a bit. We'll see if that works.
We're sharing. Comorbidity is a fancy psychological word for co-occurring disorders. For example, the same person can meet criteria for OCD and major depressive disorder, or OCD and generalized anxiety disorder. Dr. Pete was just talking about comorbidity between OCD and hoarding. And we're talking about trichotillomania with OCD, so it's really common to have co-occurring disorders. In psychology, as a lot of you probably know, there is no blood test that can tell you, yes, you have OCD. We diagnose using clinical criteria. Several people have mentioned the DSM. The DSM is the Diagnostic Statistical Manual, which contains all the categories for the disorders in psychology. So there are a number of categories with symptoms, and you have an expert that is looking at your symptoms and profile to try to match the best possible category to your experience. What that means is that it's more complex than just a simple test. So people's psychology can be very complex and unique, and sometimes what they're experiencing may not fall neatly into one category, but can be captured with not one, but two categories or more categories. I don't know how many of you were there, but last night we had a really nice talk on video journaling by the videographer Travis, and he introduced, whose video is taping us right now, and he introduced this video journal on Maria Bamford. I don't know if you guys know her, she's a famous comedian. And I thought it was interesting when he introduced it, he said Maria Bamford has OCD, depression, I think you said, and other anxiety. So if that's the case, Maria Bamford would be an example of somebody who would have OCD and maybe major depressive disorder. And it might be that those two categories can better capture her experience. In psychology, it is common for different disorders to be related in a way that sometimes they're not in the medical field, like in the physical world. Can I have my assistant? So this is an example of, for example, somebody who may have a sprained ankle or a coronary artery disease. And if you look at the symptoms, they don't relate to each other. You know, swelling, pain, redness, warmth. Somebody stepped off the curb and sprained their ankle. And somebody may just have coronary artery disease, and they may have both, but they really don't relate to each other. Can I help you? Mm-hmm. Thank you. On the other hand, if you look at OCD and depression, there's usually a lot more overlap. So for example, even if the exact criteria don't match, it wouldn't be uncommon for somebody with OCDs to have some difficulty concentrating. Or they both have the commonality of recurrent and persistent thoughts that cause distress. In addition, sometimes somebody with OCD may actually get major depressive disorder because of the interference that the OCD is having in their life. So it's not uncommon to have these co-occurring disorders, whether it's because the symptoms overlap or just because they cause each other. So just kind of to summarize, the comorbid disorders are common and better capture people's experience sometimes, and it gives us important information. Here are some specifics about the comorbidity for OCD that Dr. Stout will talk about.
So I think a couple of the things that Dr. Diaz and I really want to get across is how common this is, but also that it's really complex and what that's going to mean for you all or people that you care about. So one piece, Dr. Damer talked a bit about some of the statistics. I want to just bring some more things to life. Is that over 2/3 of people who have a who have a diagnosis of OCD also have a diagnosis of another psychiatric disorder. So that might be 37% of people are diagnosed with one other diagnosis, and 38% of people are diagnosed with 2 or more. Am I doing something wrong?
We're getting a lot of feedback. So
I know.
Just
I can.
make sure these are all off.
Maybe I'm too close or too far.
Maybe a little too close.
So further back is better? Okay, I can do that.
No, it's actually not.
Oh, closer up is better. I can do that as well. Flexible. So another thing to just kind of hone in on what this might look like for you or those you care about. The most common disorders that are comorbid, so that are also co-occurring with OCD, some research shows that major depression, social phobia, eating disorders. What am I?
Next slide.
Oh, no, it's not on the next slide. Sorry, I'll get to the next slide in a minute. There's no slide for this one. Simple phobias, panic disorder, Tourette's syndrome, and some research shows that panic disorder and GAD are common as well. An epidemiological study has shown that a lifetime prevalence of OCD ranges between 0.9 and 3.4% for women and 0.5 to 2.5% for men. So that means that throughout your lifetime, at some point, people have been diagnosed with OCD. For men, it's going to be 0.5% to 2.5%, and for women, it's going to be about 1% to 3.4% of women will be diagnosed at some point with OCD in their life. So the other piece that's showing kind of how common it is, the other piece of how complex this is my next one. So some research has used some what's called clustering to find how some of the symptoms of OCD might be clustered together. So this shows the complexity of that. Even though we might have the same diagnosis, Leonore and I might both be diagnosed with OCD, it might look very different for us. So what they did was kind of find that how people are diagnosed with other disorders might look a little bit about how their symptoms of OCD are categorized. So the first one that they found was factor 1. So people who have symptoms of aggressive obsessions, sexual obsessions, religious and somatic obsessions, and checking compulsions were more likely to be diagnosed with anxiety disorders, other anxiety disorders, and depression. Next. With the second factor, people who had symmetry obsessions and symptoms of repeating, counting, and ordering or arranging compulsions are more likely to be diagnosed as well with bipolar disorder, panic disorders, or agoraphobia. Next one. And then people who were diagnosed with OCD and had symptoms of contamination obsessions and cleaning compulsions were more likely to be diagnosed with eating disorders. Stop there. So an interesting piece, too, was that people who were had the first and second factors were also more likely to have an earlier onset of OCD. So this is just, I thought, pretty compelling because 2 people with OCD might look very different in their symptomology, and 2 people diagnosed with OCD might have very different co-occurring disorders. So that just really kind of speaks a bit to what Leonore was saying, is that it's really complex. It really can look very different and can be very different than a medical model, which it can be really clean cut as to I've had this blood test done and it shows I have, artery disease and it looks exactly like this. It can look really different for different people with a psychiatric diagnosis. Another thing that I wanted to talk about then with a complexity is that some of the symptoms may overlap. And Leonore touched on that a bit. Something that could be difficult is that while you might have symptoms that overlap, they also might not meet full criteria. So I might have meet criteria for OCD, but I might have a couple of symptoms of another disorder, but it doesn't fully meet criteria for an eating disorder, what have you. And that might be a difficult thing then for your treatment, for what that means for working with your therapist. So it might take a while for them to come up with a good diagnosis and to have a good plan for treatment too. I don't have any more slides on this.
The other aspect about treatment is that when you do have comorbid diagnosis, sometimes A therapist may be really well versed maybe in treating OCD, but maybe you have an eating disorder, and they may actually refer you out to somebody who's more of a specialist in eating disorders because maybe they don't have the expertise. The other thing that can happen, though, is that when you're actually treating the OCD, maybe if you have major depression as well, that may subside because of the treatment with OCD. So these comorbid disorders can really affect treatment.
Yeah. So yeah, you might end up having more than one therapist who's working with you on your comorbid, your co-occurring disorders, or you might find that having a therapist who's working on some of the underlying pieces of hopelessness or perfectionism really gets at the symptoms for all different things that you're struggling with. So it really kind of makes this treatment piece more complex. So I think those are really some take-home messages, that this is very common, but it is also really complex, and that affects treatment as well.
And just one more thing I thought of is what Dr. Stacy was talking about, that it also may, because she works a little differently, that it also may affect the type of treatment that you get and the approach that the therapist uses, depending on your comorbidity. Check. Can you hear me?
Yes.
Yes. Can you hear me? All right. So before we transition to treatment, we have a demonstration. This is on the obsessive thoughts aspect of OCD. We have our aspiring actors and actresses here, Academy Award winning. So in this first part of our demonstration, Thomas is going to represent someone who has OCD, and he's trying to write out his grocery list before he goes grocery shopping. Now for Diana's role, you got to use your imagination a little bit. She's actually not going to be a person, she's going to be an OCD thought inside of Thomas's head. So we're really testing out her acting skills today. So while this is going on, we would like you to observe Diana and Thomas both as well as the interaction. All right, let's go ahead.
You want to stab your dog. I think you want to stab your dog.
I want to stab my dog. It's terrible.
Well, why would you be having the thought if you didn't want to stab your dog?
I don't know, but I mean, I don't want to. That sounds terrible. I love it.
Prove it.
I don't know. I mean, well, think how many times I've had wonderful experiences with him, and I like pet him and I take him out. I love him. He's a great
I
dog.
forgot to take him for a walk last Tuesday. If you really cared about him, would you have done that? And would you be having these terrible thoughts about stabbing him if you really loved your dog?
That's a good point, but I mean, I would never do that. I'm not.
Are you sure? Because you're having the thought. Why would you be having the thought if you didn't want to stab your dog? It's a pretty crazy thought to have, don't you think?
I'm pretty sure. I mean, when I think about it, I feel better, and I don't know.
Well, I think you really want to stab your dog.
All right, so for this first part, what did you all notice about Thomas in this scenario? She says he was trying to rationalize his thought and trying to connect it back to reality. He seemed frightened to have that thought show up. I'm repeating this to make sure everybody can show up all of a sudden. All right, so let's look at the second scenario. Oh, I'm sorry. In this scenario, what's happening in between is that Thomas went to get treatment for his OCD. So let's see what happens when Diana decides to pay him an unexpected visit again.
You want to stab your dog.
No, I don't. That's
You're having the thought, you must want to stab your dog.
okay. I remember this from treatment. You're my OCD thought. You're my obsession. I'm not going to fight with you. You're an OCD thought. I'm just going to focus back on it.
You want to stab your dog. You don't really love your dog.
You're just
What
my
if that
OCD
was-
thought. I remember this. This is my obsession. I'm just going to label you and focus back on my work again.
You know you want to stab your dog. You can just visualize it. You want to do it. Maybe you're going to do it. Maybe you've already done it.
In my OCD, I remember.